Hello, Gabs.
Hi, Katie.
Welcome to Pip.
Thanks. It's really good to be here.
I'm so excited. Today is a slightly different episode that we're bringing you, and we're hopeful that it will become a little bit of a series. So this is our first episode of Evidence in Action. I felt like we probably should have made some kind of little tune to go along with it.
I sing one. We'll do it
Another
later. We'll do it
theme
later.
song. But the intention of these episodes will be, I suppose, to go through one specific item or piece of evidence in relation to a specific topic or that kind of thing, and unpack it a little bit, but also talk about how we apply it
For sure.
as therapists.
Absolutely. I think it would be so cool if our listeners leave feeling like what they can do or something they're not quite doing it is backed by evidence.
Yes, 1,000%. And we know, I'm not going to speak on everyone's behalf, but I'm going to speak on my personal experience. I don't love sitting down and reading, in this case, a 200-page document.
It takes a special kind of person.
It does, but that's not to say we do. If you've listened to any of our previous episodes, Danny, our colleague, loves to read and learn about the updated evidence and that kind of thing. So, but we know that particularly for newer grads, it can be really hard to know where to find good evidence.
Yep.
How to make sense of it and how to actually use it in your practice.
100%. There is so much out there, and because we work with people, it's just so complicated.
Yes.
And you can't just set up a research project and do it. Some of it's so old, some of it's new, some of it's tiny.
Yeah.
So we kind of want to do some of the work.
Yes.
And break it down.
Yeah. So today we are speaking on the ADHD Guidelines, which were published in 2022. I'm going to look at my screen. They are done by the Australasian ADHD Professionals Association, or AADPA.
Yep.
And as I said earlier, it is a big document, but it's been developed for clinicians or health professionals, anyone that's supporting those that are exploring or have been diagnosed with ADHD. And they do also outline that they are aware that perhaps families and individuals will probably go through these guidelines as well.
Yeah, for sure.
But they are a really in-depth guideline that we have discussed at length as a team, and we whip them out often with families. So we thought it would be a really cool one to start with.
Yeah, for sure. And it's fresh. It's
Yes.
like it's new.
Yeah.
Like I said before, very often we're like really digging through the dirt to find research.
Yes.
This is like, and for those who don't know, clinical practice guidelines, they're kind of like the pinnacle of evidence for us. They sit at the very top. It's synthesized, it's summarized.
Yeah.
So this is a good one to start with. I agree.
Yeah. So I suppose when we're thinking about these guidelines and how people might like to work through them or look through them, why would someone pick up guidelines like this?
Good question. Well, I can kind of really only speak for myself.
Yeah.
I love picking up guidelines for the confidence it brings me.
Yeah, great.
It teaches me kind of like new things.
Yep.
But it also helps me deliver to parents and also to kids things that, I'm really sure are evidence-based, so I can either assume or help the care team or the parents or the school do similar.
Yeah.
And the guidelines do go into all the different pieces that come into therapy, all the care team members and things like that.
Yeah.
So I think it kind of serves for me as a little like home base when I'm not sure. I can come back to it and then move away from it again. But I think we're going to talk about how it's not, evidence isn't the end all and be all when it comes to evidence-based practice.
Yeah. So when we are using our guidelines, we are really using that in the way that we want to be evidence-based in our practice.
For sure.
And previously when we present on topics and develop webinars and that kind of thing, we will always speak to what makes up evidence-based practice for us as clinicians, because it's not just the clinical evidence or research.
For sure.
So when we're thinking about that, there are 4 intersections that we often look at.
Yep.
And we have a lovely little visual that we're going to pop on your screen if you are watching. But if you're listening, we're going to go through them as well. So Gabs, outside of that clinical research and evidence, what else do we need to consider to be evidence-based practice?
Yeah. So outside of that, you have your client values and circumstances. That's kind of, you know, the client themselves, what they like, what they don't like, what they believe in. Kind of culture falls into here sometimes too. Other than that, we have information from where they are. So the context. That might be where they live. That might be the people they live near. That might be religion if they're very tied to that. Context really important in determining what's the best kind of course of action to do in therapy. And then the last one is your clinical expertise. It's actually what you know. So
what you can bring to it.
Yeah, for sure. And that might be things like, you know, that this is outside of ADHD, but it works well with clients like this, you know, similar to this in this way. And then you're borrowing things from bits and bobs to create your practice.
And so when we are using these ADHD guidelines, obviously we want you to still be thinking about those other components of being that make up that evidence-based practice.
And I think that's
as well.
I think that's really, really important because as we go through the guidelines, yes, they're really dense and heavy, but actually because kids are so complicated and people are so complicated, in the scope of it, they're not that big. You know, they detail just a tiny part of our job. So if you're only ever focusing on research evidence, you're going to get quite stuck. You're going to think what next really, really often. When you're in that what next phase, that's when you can borrow from those other three bubbles.
Beautiful. So if we're looking at these guidelines, I suppose like we said at the start, we want to think about what they say and what they recommend, and then what does that actually look like for us as clinicians. So if we're sort of starting at the what they say and what they are trying to communicate to clinicians using these guidelines, I wonder if we could even start with ADHD as a starting point, and what it speaks to in terms of core symptoms and go from there.
So the guidelines do a really great job of breaking apart what's a core symptom and essentially, for lack of a better word, what's not. They refer to core symptoms like as hyperactivity and inattentiveness. You know, those are your kind of like staples. That's what ADHD presents as. Everything else falls into things that it's kind of like a cause and effect, like a domino. You know, it comes from the experience of having ADHD. That might be anxiety. That might be being concerned about what your peers think. That might be struggling to manage workload. You know, those are your kind of other things that are caused usually by the core symptoms.
And I should also highlight that if you are listening to this or you have listened before, you may or should be aware that we work in pediatrics. So we work up to 18 years, but that's not to say that ADHD guidelines have been developed for all ages as well. So there might be some things in there if you do work in the adult area that we don't necessarily cover, or we might not get to today, that might be more relevant to your practice as well. But we do know that that core symptomology is pretty well understood in terms of what we might see and what that diagnosis presents with.
For sure. Absolutely.
So then once we sort of look at those core symptoms in the ADHD guidelines, they then sort of break down into what are the recommendations in terms of pharmacological and non-pharmacological as well. So from your research through this and what you've been reading and that kind of thing, what do we know about pharmacological versus non-pharmacological for ADHD? And obviously when we're sitting here as therapists, we're on that non-pharmacological side.
More often,
but that doesn't necessarily mean that we don't talk about.
100%. We definitely talk about it. I talk about it all the time. Look, a lot of it falls into understanding the roles of each of them, right? And if we bring it back to core symptoms, pharmacological is all about core symptoms. You know, it's all about the inattentiveness and the hyperactivity in your brain. So what's happening in the brain? Things that you really cannot change without targeting like the brain itself. We're talking about like chemistry.
And we did discuss that in our recent attention episode, because we hopefully not too many people were let down when we said that inattention can't actually be improved non-pharmacologically.
Yeah, don't remind me.
Sorry, but it is. It's like you said, it's a brain matter.
It is.
So often we do see, and the ADHD guidelines are really clear in that some families, I say families because we're working with families in this environment, but some individuals or parents or caregivers might go down the pharmacological road first. They might go down the non-pharmacological road first. What does it say in the guidelines around which path?
It actually says it doesn't technically matter.
Great.
Essentially, it depends on your circumstances.
Yeah.
I think I have two great examples.
Yep.
For example, if you bring your child over to OT and they just cannot sit still or focus.
Yeah.
They're trying their very best. We are seeing that they're trying their best, but it's just not working. You've built rapport. You've ticked all those boxes.
Yeah.
That would be a fantastic opportunity to go, look, we're talking about medication here first.
Yeah.
It's not that you didn't try this first, but medication is what's going to enable this one.
Yeah.
Right?
And I've absolutely had clients over the past years where we've covered so much in therapy, but when they're coming to therapy, and particularly if we're looking at kids that are coming, after a full school day, they're coming to a 5 p.m. appointment, that kind of thing as well. If their body and brain is not in a regulated state, you can do all the teaching of the content that you're aiming to address the goals that you've set with that family, but that child's brain just may not be able to actually take that information in.
And in many ways, it's sometimes like counterproductive.
Yes.
When we're talking about those not core symptoms, coming into a place and focusing for an hour on things that you just cannot do would kind of cause you to not like therapy.
Yeah, absolutely.
In those moments, that's when I'm looking at, let's really refer onto, to look at medication.
Yeah.
And then look at getting back in here, because boy, could we do a lot.
Yes.
On the flip side, on the other side of the coin, what we're talking about is, I think of like wait lists.
Yep.
Yes,
100%.
If they exist, they're like real.
Yeah.
Right.
Yeah,
and sometimes just wild.
Yeah.
If you are on the wait list for even like a doctor, for a pediatrician, and you're just not sure what to do, starting therapy, there's no harm from that. And the guidelines bring it in and say, just start start whatever you feel like you can.
Yeah. And that's the thing. We do know that therapies often have quite long wait lists, but we are very well aware that pediatricians in particular are really, like, some of them have just completely closed their books off because they do not have capacity.
Yeah.
So if we have families that are like waiting for that pediatrician appointment before they do anything, we can confidently communicate to those families, you know what, like, engaging in therapy whilst you're waiting for that is still helpful.
For sure. And yeah, absolutely. I agree.
Yeah. So when we look at that, I know that you also spoke to, when we were discussing, we were talking about like the lifestyle side of things as well that the ADHD guidelines outline, which talks a little bit about us ensuring we're looking at things like sleep and that kind of thing. Do you want to speak a little bit on that?
So the guidelines, and it's kind of what we're going to do today, breeze over it a little bit. They mention that, like, clinical expertise, it's look into it, essentially. And we know that sleep impacts your cognitive function, and we know that attention is a cognitive function in your brain. So like 1 + 1 + 1, sleep impacts attention. And same with diet. Like we know that there's some things in there, not as much as sleep, but they exist. When we're talking about our practice and how to use it then, it's about checking in, potentially if the, child is just really dysregulated and their sleep patterns are way off, prioritizing sleep hygiene to just see what you can do might be a way to go. But we're not going to dive too much into sleep because that's an episode for another day.
Yes, it is, It's not on the list, actually, but I think it would be a really good one.
Nah, I'll watch that one for sure.
Do you need all the tips? So I think what's really helpful to know as well from the ADHD guidelines, and it's something that I will often use in my practice when we're coming back to that idea of what our kind of two paths are here, is that we know that they're addressing two different things, essentially. We know that the pharmacological side, like you said earlier, is really trying to go down that pathway of core symptoms.
Yeah.
Our non-pharmacological side of things, it's suggested that that is really to be enhancing well-being and quality of life, essentially.
For sure. And managing, once again, that domino effect of ADHD.
Yeah.
Super important.
Yeah.
And the ADHD guidelines touch on it's about both.
Yeah.
It's about both pharmacological and non-pharmacological.
Yeah. And so do they say that they work best hand in hand?
Several times.
Yeah.
I read it several times.
Yeah.
It absolutely does. Doing both.
Yeah.
There are circumstances where potentially you might just do one.
Yeah.
Usually that's when, if you do one and the symptoms reduce enough that the impact of it aren't significant enough, that's when you kind of want to do both. The other one is if medication doesn't work for you, which is a very real thing. And I don't want to dismiss that for a lot of young people with ADHD that, the guidelines are saying medication is the way to go and trial. However, if you've tried it and it's not for you, that's also okay.
Yeah.
Those are the two kind of moments where I think you wouldn't do both in joint. However, if those things are off the table, typically I would say both. That's what the guidelines recommend.
And I do find that in my role, because we will here at Kid Link, at least we do see our clients fortnightly, whereas, and that might be different for all clinicians, but typically if a pediatrician prescribes some kind of medication, they're probably not going to see that client weekly or fortnightly.
For sure.
So I do find a lot of families coming to therapy and saying, we just got prescribed this. This is what I've noticed.
Yeah.
And I know the guidelines are really clear around like making sure that there is really close reviews after that medication is prescribed as well.
And I do believe, Katie, that that's something, especially because, as you mentioned, you might see a pediatrician once and technically the guidelines recommend almost like I believe it's weekly and then monthly, and then they move into yearly or something like that. But if that's not possible, supporting parents to recognize any improvements or side effects, and it might be a journal, it might be some prompts for them to look out for. Things that come to mind are like eating. That's what I get a lot of families coming to me and saying, he's just not eating.
Changes in diet, or then coming home after school and just eating 4 meals in one sitting.
For sure. And the guidelines do touch on that. And I kind of to and fro about bringing it up, but I think once again, it's a bit of a bigger matter. There's too many like individual, like contextual things, but helping parents keep an eye on it, that does no harm. And I've found, particularly probably in like my adolescent clients, that often they are a really good source of that information as well. But they will recognize shifts in their internal state or all of those things that we might be looking for. They might be able to actually give us some information as well, whether that be positive or negative from their perspective as well. So I guess then when we go down that non-pharmacological side of things, what do you think clinicians can take from it that they're like, yes, I can use this. This is stuff I can do. And I know that it's backed by the evidence here. I think it would be useful for us to go down a little bit of a timeline kind of thing. So if I think about right after you've tried medication, it's like the first 2, 3, 4 weeks of medication. One thing the guideline touches on is the effects of suddenly having like this ability to attend to tasks, which means you're also able to like reflect on your own thoughts, and it just doesn't feel good for a lot of young people with ADHD. That's a perfect example of something that's related to a core symptomology.
Great.
In those moments, it's all about empathize. Empathy, and really understanding and listening. But if we kind of keep going down that timeline a little bit, the guidelines really emphasize like cognitive behavioral therapy and informed kind of strategies for both under 5 and from 5 to 18, and then also 18 onwards. But that's not our scope.
Our jam, is it? if that's your scope, definitely go and have a look at what it says on that area.
100%. Which I also think it's one of the big things we want to talk about. This being evidence in action. It's like, how do we take that evidence that they're saying you should do these kinds of things, and how do we apply it in our sessions?
Yeah. So we do, being a family centre practice, we do a lot of parent education and psychoeducation. What do the guidelines say around that?
Yeah. Once again, heaps. I think they have a huge section on it. A lot of it's about first supporting the parent in understanding the diagnosis. That might be empathizing with them. That might be helping them understand the difference between core symptomology and not core symptomology. It's also about medication, you know, supporting them to understand when expectations are like just right challenges or not.
That's really like, because I was thinking about that when we spoke about it in the attention one that we spoke of. If your child is not medicated and does have difficulties with attending to tasks or whatever it might be, that it can be really powerful for us to support the families to at least understand what their current or previous expectations were and where we might need to adjust them as well.
Absolutely. It's really hard.
Yeah.
You know, I really empathize with the parents.
Yeah.
But it's definitely easier than pushing something that a child just cannot do in that moment.
Yeah.
We rather reduce the conflict and improve the whole like peace at home than to keep pushing for something that's just not a just right challenge at the moment.
Yeah.
But yeah, education's really crucial.
Beautiful.
Crucial.
And then you did mention as well that, it might come with that increased awareness of internal thoughts and that kind of thing. So how can we then start to build on that using those CBT informed?
Yeah. I think a lot of the therapists here, we all do the same. We believe in the same things, but we do it a bit differently.
Yeah.
The way I tend to approach is over 5.
Sure.
You know, maybe we'll start there. Under 5 is a bit different, and the guidelines touch on that.
Yep.
But over 5, I kind of start looking at things like our flashlight, being able to point it outwards and like get them to recognize on the things that what they're thinking about, you know, what they're playing, if it's Minecraft, if it's Roblox. I don't love Roblox. I love Minecraft. But starting there so they actually can go, oh, that's what I'm thinking about. And then helping them point it inwards to go, oh, that's what I'm thinking about.
Yeah.
This ties in really closely then with your like triangle between thoughts and feelings and actions.
Yeah.
And I kind of move from thoughts to feelings, because once we start going, oh, this is what I'm thinking, we're left with that like, oh, yikes moment of like, now that feels yuck. I don't want to think about what Gabs is telling me to think about, right? So I help them recognize that emotions are, you know, they're meant to be felt and that they're just emotions.
Yes.
There's no such thing as bad emotions.
Yeah, really normalizing that for them. Yeah. It's really interesting, I think, because like you said, we all do things differently as clinicians. And that's like, our aim is not to sit down today and say, here are some like activities that you can go away and do. But what we really hope is that we start to think about, like the foundations of what these guidelines are saying and how you might use that. Because I agree, like I've used that flashlight previously, and I'm trying to think of this particular client. She was on that border of like, she must have been grade 1, so 6, 7 kind of thing. And although it was taking her some time to pick up that learning, her mum found it a really powerful concept to use and the language to use for her, but also to adjust her expectations of where her daughter's flashlight might be / needs to be.
Absolutely.
So it might not necessarily be that your aim of your therapy activity is just for the child to walk away with this
flashlight,
you know, huge new understanding or strategy as well, but also giving the families something that they can apply in their natural environment.
One thing the guidelines emphasize as well is to do like CBT informed strategies. It's having the parent in the room.
Yes.
They talk about groups and things, but at the very least, if you're working with a child, the parent should be there too to support that at home.
Yeah.
It's really clearly mentioned in there.
Yeah.
And I think that's really, really important, because as you're doing it with the child, usually the parents start to have these little epiphany moments of like, oh gosh, you know, I'm asking them to do homework and my flashlight's way off.
Yeah.
But I'm expecting his to be completely focused.
Yeah.
So helping parents recognize their thoughts is really big on this one. We also do a lot of like role modeling. Like I help parents role model stuff.
Yep.
Role model the language, role model the strategies. The good rule of thumb, particularly for ADHD, in my opinion, is if you can't show them, like, can be really hard to learn.
Yeah. I love that. But I do think, it's interesting that you say that as well, because I'm imagining there might be clinicians listening that are, sole traders. They might go into the school and work with the child. They might not necessarily have a parent or caregiver there. Yeah. So I suppose we would probably really encourage you to be having a look at these guidelines and thinking about how is it possible that you work in that psychoeducation and parent education and into that child's therapy plan, I suppose.
Absolutely.
Because we're very lucky, 99% of the time we have some kind of caregiver in the therapy session for the whole time, because we only really do clinic-based except for observations and that kind of thing. But in saying that, we historically did
and I've worked in clinics. Similar.
And it's so hard because you kind of feel like, you do all this great work with the child. The child seems to really pick up what you're working on, but then you see them 2 weeks later and you're like, what happened in between those two sessions?
In between, right? For sure.
Yeah. So I think it's really important for clinicians to think about, how does that fit into your practice 100%. As individual therapist as well.
For sure. And before we kind of move on from the CBT space in this area, I would love to know kind of what activities you I know that we said we're not going to go into nitty gritties, but I just want to know your favorite, I love thought journals, for example. I love giving out thought journals. And I have it built into some session notes, getting clients to reflect on what they're thinking about at home. Yeah. And then coming back and saying, like, look at all these things I wrote down. Yeah. And then we can talk about their thoughts. Yeah. So important to be able to help them attend to tasks. Yeah. If your thought's not on what's happening, you're not attending. Yeah. You're not encoding, which I know you guys spoke about,
Do you know what I find? And it's more like a activity I like to do in therapy as a sort of just as almost an introductory to being aware of your thoughts, is I love popping on. I'll get them to tell me interest area or something that they like, and I'll get them to put on a video on YouTube on that. So, for example, one of my teenage clients that I have, he popped on a NBA clip, I believe.
That's soccer, right?
Really likes basketball. But I sort of got him to, we had a bit of a visual tracker, and I just wanted him to kind of track as much as he could with some kind of, even if it was just a dot, when a thought came up about what he was watching and when a thought came up that was not necessarily about what we were talking about or looking at. And it was very minimal in that they were 99% of them were about basketball. I then put on a Taylor Swift video for him. I think I might have put on like the start of her documentary or something.
Oh, that's so cruel.
It's funny because, he was like, I actually don't mind Taylor Swift. I was like, that's not really what I needed, something that you weren't going to be interested in.
But you can't change off Taylor Swift at that point, right,
no,
Katie?
I can't. No, I've already put it on. But then doing the same exercise and being like, okay, when we're doing something that perhaps your brain doesn't find as interesting, where do your thoughts go, kind of thing. And I think that that's and something that families can practice at home as well, because it might be conversationally, they might be like, I really want to tell you about my day, but I also want you to check in with your thoughts during that.
Yeah, for sure.
So that's probably something that I like to do.
I love that. And I want to bring it back to medication here in terms of what you're doing is managing the effects of the core symptoms, right? Yeah. Inattentiveness is like you are getting distracted to your own thoughts about what's happening around you typically. Yeah. Recognizing that is step one to be able to go bring it back, pull my flashlight back. If we can't recognize it, you're just swinging that flashlight wildly, right?
Yeah. And it is, and then that's where it has that functional impact usually. For sure. No, for our kids in classrooms and that kind of thing.
Definitely going to be listening to Taylor Swift.
I love that. So I'm super aware of the time and how long we've been doing this. So I suppose in wrapping this up, is there anything else that you're like, I desperately want to touch on this or? Yes. Yep.
I think probably the biggest last thing I want to touch on is under 5. Yeah. The focus being mostly on developing emotional regulation.
Yeah, great.
What's missing under 5 is that self-awareness. Yeah. Everything we spoke about is being able to recognize your thoughts. Yeah. And even though we do it often, and sometimes I wish I could get out of my head, under 5 just do not have that recognition yet. Yeah. the guidelines bring it in that you should focus on like emotional literacy, supporting them to be confident, developing their self-esteem so that when they start to build that self-awareness, it's a much less bumpy ride.
Yeah. I love that. And that would have a huge component as well in terms of supporting families in modeling emotions and like you said earlier, normalizing all those emotions and that kind of thing. But that's the thing. We do know that under fives, the expectation for them to have that awareness of their cognitive processes and thoughts, it just isn't realistic. So again, you might need to adjust families' expectations there too.
Absolutely.
Yeah.
It ties in as well with school. Yeah. Supporting schools to be educated. The guidelines touch on it too.
Yeah.
Supporting schools to have someone who is trained in understanding ADHD. Yeah. And it also brings us into it as well. Like it mentions observations for both under 5 and over 5, wrapping our heads around the school environment, training and things like that.
Yeah, great. Well, Gabs, I have really enjoyed having you.
Oh, thanks for having me, Katie.
I hope that you feel good about this and you walk away and you come back. But this was our sort of first evidence in action one. So the aim will be to bring you these maybe, once every 6 to 8 weeks kind of thing.
If I can squeeze in practice guidelines, oh my gosh.
Yeah. But we will pop in the show notes, obviously, the links to the clinical guidelines. We'll also pop in there's a really great version of it for consumers, I guess, like parents and caregivers, which I've found really helpful to email families once we've had some of these educational sessions and that kind of thing. So we'll pop the link in there. Cool. And we will see you next time you're in the seat.
Yay!
Thanks, Gabs.
All right, see you soon.
Bye.
Bye.